Work hard, dream big, and never give up. You will definitely get your destination if you adopt all these principles. Now, coming to the diagnosis of rheumatoid arthritis, it consists of history and examination. Number two, blood test. Number three, imaging, X-ray, MRI. And number four, ultrasound. First, history and examination. The patient gave history of pain and early morning stiffness, which is more than 30 minutes, and seen in wrist, hands, knees, and ankle joints. Same joints are involved on the both sides of the body, and examination, two or more joints are swollen, tender, warm, and these are painful. Now, the next step is blood test. Rheumatoid factor, it's non-specific, seen in 70 to 80% of the patient of rheumatoid arthritis, but also seen in 10% of the healthy people. Also, it has been seen in hepatitis C, tuberculosis, subacute bacterial endocarditis, and syphilis. Chronic autoimmune disease, Sjogren syndrome, and systemic lupus erythematosus. So it is going to give you the false positive results. So one cannot totally rely on rheumatoid factor. The other test is anti-CCP antibodies. It is more precise test as its specificity is about 90%. The third test is anti-nuclear antibodies. It is seen in about 20% cases of rheumatoid arthritis. Then there is a one more new test which is called anti-MCV. That is anti-modified citrullinated vimentin for the early detection, and its specificity is 99.7%. So it is the most accurate test for the rheumatoid arthritis. Then we go for the CBC, in which we see the anemia, leukopenia, platelet count increased, and there is renal function test, LFTs, ESR, and CPR, which are all raised, giving the clue of rheumatoid arthritis. The next step in diagnosis is imaging, that include X-ray and MRI. There is no change in X-rays during the early part of the disease. First X-ray of the hands and the feet are done, then other joints are done for X-ray. X-ray shows osteopenia near joint and a smaller than normal joint space. Juxta-articular osteoporosis, joint erosion is also seen. Magnetic resonance imaging show more detail of the changes seen on simple X-ray. So here one can see the rheumatoid arthritis on X-ray. There is soft tissue swelling, as one can see. There is periarticular osteopenia, and there is joint space narrowing, and there is marginal erosion of the bone, which are all seen in the rheumatoid arthritis. And here one can see when there is extreme rheumatoid arthritis, the bones and joints and the interphalangeal and metacarpophalangeal joint, these are all involved, and one can easily recognize the changes on simple X-ray. And here again, one can see the rheumatoid arthritis involving these interphalangeal joints, then metacarpophalangeal joints, and the other joints of the hand. And here one can see the Z deformity of the rheumatoid arthritis and the ulnar deviation and other things which are seen in this hand. These are all abnormal finding giving clue of rheumatoid. Then next step in diagnosis is ultrasonography. It is more sensitive than radiograph to detect bony and soft tissue changes. Technical advances in ultrasonography like high frequency transducers are used nowadays. Color Doppler and power Doppler ultrasound to assess degree of the synovial inflammation, that is showing the active synovitis, as synovitis is the best predictive marker of the future joint damage. So here one can see the synovia, and that is without the contrast. No contrast agent has been used, and now if the contrast agent has been used, then the image contrast agent can clearly show the synovium which is abnormal. Now, differential diagnosis of rheumatoid arthritis are: number one, crystal induced arthritis, that is gout or pseudo gout. So, do aspiration of the joint fluid that shows presence of the synovial urate crystals, x-rays for the gouty tophi, and pseudo gout to show the calcium deposition, and check the uric acid level in the blood to rule out whether it is gout or not. The second differential diagnosis is osteoarthritis. Do x-rays of the affected joint and the blood test seen in the osteoarthritis seen in the older age, and it spares the wrist and the metacarpophalangeal joint. No constitutional manifestation are seen as seen in case of rheumatoid arthritis. The third is psoriatic arthritis, and that resembles the rheumatoid arthritis, but in psoriatic arthritis there are nail changes and the skin symptom that distinguish it from the rheumatoid arthritis. As one can see, the gout, the bone erosion, and urate crystals in the tophi and the synovium, one can appreciate that. And in osteoarthritis, one can see the healthy knee joint, and there is hypertrophy and spurring of the bone and the erosion of the cartilage, that is the hallmark of the osteoarthritis, that is not seen in case of rheumatoid arthritis. Then one can see the psoriasis and the psoriatic arthritis. These are the here the joints are involved, but there are also the skin changes, the scaly skindian which are present on the body that distinguish it from the rheumatoid arthritis. The fourth differential diagnosis is systemic lupus erythematosus. Specific clinical symptoms like malar, rash, photosensitivity, discoid skin lesions, and the alopecia are present. The higher titer antibodies to the double stranded DNA is diagnostic of systemic lupus erythematosus. There is glomerulonephritis and central nervous system abnormalities also seen. Number five is chronic Lyme arthritis. It causes erosive arthritis and resembles rheumatoid arthritis, but it only involves the knee joint. Do the blood test. Positive serological test in endemic areas gives the clue of Lyme arthritis. Number six is axial spondyloarthritis, including ankylosing spondylitis. It involves the spines, but rheumatoid arthritis, like symmetrical small joint polyarthritis, may also seen in this axial spondyloarthritis. There's the fusion of the joint also. So here one can see the systemic lupus erythematosus their mallar or the butterfly rash, and the other involvement of the systemic lupus erythematosus seen besides the joint pain and joint involvement. And here there is chronic Lyme arthritis. There the history of the tick bite, which is about 4 millimeter long, and there is bull's eye rash, and there is also the involvement of the joint. But these manifestations are also there. Here one can see axial spondyloarthritis and normal curve of the spine as one can appreciate, and here loss of the normal curvature of the spine is there, and the new bone formation causing the spinal fusion here. So that's why there is the loss of normal curvature as one can see in case of the normal S curve of spine. Now the seventh differential diagnosis is reactive arthritis. Previously it was called Ritter disease. It involves the heel, sacroiliac joints and the large joints of the leg. Also there is urethritis, conjunctivitis, iritis, buccal ulcers, and keratoderma blepharographia positive in the reactive arthritis and not positive in rheumatoid arthritis. And number 8 is hepatitis C infection, rheumatoid like symmetrical small joints, polyarthritis occurs, and rheumatoid factor autoantibodies are positive, but anti-CCP antibodies are negative. So that is the distinguishing point of hepatitis C arthritis. Number 9 is metastatic arthritis. Many cancers produce rheumatoid-like polyarthritis with the clubbing, but they do not have the rheumatoid factor that is negative, and the cancer metastasizes to the bone to give the feeling like the rheumatoid arthritis. Here one can see the reactive arthritis or the Ritter syndrome. The eyes are involved and then the joints are involved. And here hepatitis C arthritis, the many joints, small joints, large joints are involved, and that is causing pain, but they are not giving the RA factor positive. Similarly, here one can see the metastatic arthritis, that is the different tumors of the kidney, lung, and liver. These can metastasize to the bone and give the pain in the bone and the feeling like rheumatoid arthritis. The 10th differential diagnosis is adult onset still disease, AOST, joint symptoms of having destructive arthritis of the wrist, anemia and leukocytosis, sometimes more than 40,000 cells per microliter are seen. Ferritin level is very high, more than 3000 milligram per milliliter in 70% cases. Reason why it happens so is not clear. And then rare causes of the differential GERD are number 1, sarcoidosis, amyloidosis, and the Whipple disease can resemble the rheumatoid arthritis. Hemochromatosis cause hand joint arthritis. Acute rheumatic fever by streptococcal infection that has the accompaniment of migratory arthralgia, but here there is increased ASO titer which gives the clue of acute rheumatic fever. There is carditis and erythema marginatum, chorea, and the subcutaneous nodule to differentiate from the rheumatoid arthritis. Here one can see the adult onset still disease. The person is having the pain on these areas, and here there is sign and symptoms of the sarcoidosis. One can see the eye pain, the vein problem are there, cough, troubles, breathing problems, the respiratory syndrome, the joint pain, and the swelling is also there, and the lumps or spots on the skin are there, and these are the hallmark of sarcoidosis. And Whipple disease also give the joint pain, but this Whipple disease also have the diarrhea, abdominal pain, and weight loss, but it also present with the joint pain, and it is being caused by the bacteria. Then amyloidosis can also give the pain in the joints because of the deposition of the amyloid material and causing the pain. And here one can see the acute rheumatic fever that is giving the pain in the joints, and there is migratory arthralgia that is the classical for this acute rheumatic fever. The continuing the rare causes of the differential diagnosis, bacterial arthritis by Streptococcus bacteria usually asymmetric, but rheumatoid arthritis involves both sides of the body symmetrically. So, if asymmetrical, one can think of septic arthritis or the arthritis by Streptococcus. Then, next is gonococcal arthritis, bacterial arthritis, initially migratory, involves the tendons around the wrist and the ankles, and the synovitis is witnessed. So, do the ultrasound to see the changes. The next is polymyalgia rheumatica, polyarthralgia over the age of 50. Rheumatoid factor is negative. Proximal muscle pain and the stiffness on the shoulder and the hip girdles has been seen. And here one can see the septic arthritis. If you just take the fluid out, it will be synovial fluid. It will be red or containing lot of pus in that. And here is the disease polymyalgia rheumatica that is having the area of pain of the shoulder and this hip joint and other nearby area. So that is polymyalgia rheumatica. And this is gonococcal arthritis, arthritic changes in the right knee and culture of the fluid. If you do the aspiration of the fluid and you do culture, the test will be positive for the gonococcal bacteria. So that is called gonococcal arthritis. The other rare causes are human parvovirus B19 infection. In adults, can mimic the early rheumatoid arthritis. IgM antibodies to parvovirus B19 are present and arthritis resolves within weeks. The next differential diagnosis is spirochetal infection, arthralgia, more prominent than arthritis, rash on the cheeks, torso, and the extremities is common to differentiate it from rheumatoid arthritis. The beautiful man-made from the tree modification and wood-made craft with a cap look like to be a man playing with the football. It's really artistic and one should appreciate the effort of the artist. Now, coming to the management of rheumatoid arthritis, there is no cure for rheumatoid arthritis, but the treatment improve only the symptoms and causes slow progress of the disease. The goals of the management are reduce inflammation, pain, and the swelling, to preserve day-to-day functioning and to prevent the bone deformity. So the management include lifestyle, physical and occupational therapy, non-steroidal anti-inflammatory drugs and analgesics, corticosteroids, disease-modifying anti-rheumatic drugs, DMARDs, synthetic and biological, alternative drugs, and surgery. First, we are going to have something about lifestyle. Regular exercise to maintain muscle strength and physical function, diet have no effect. And number two is physical and occupational therapy. Physical and occupational therapies definitely help, and it include systemic rest first. Depends on the presence and the severity of the inflammation. 2 hours of the rest per day, continued rest till the improvement is there. The other part is articular rest, that is, decrease articular inflammation by the joint rest and lie in the prone position several times daily as a part of the articular rest. Then, physical and occupational therapy. The third parameter is hydrotherapy. Here, buoyancy of the water permits maximum isotonic and isometric exercise, no stress on the joints than the active range of the motion exercises. The next step is heat and cold, used primarily for the muscle relaxing and analgesic effect. Radiant or moist heat is used. Local application of the cold give relief to the joint pain. And next step is weight loss will definitely reduce wear and tear on the arthritic joints of the lower extremities. And here one can see the hydrotherapy or the water therapy. And here one is putting feet in the water. And there are certain assistive devices which I am going to tell you. And elevated toilet, which are these assistive devices are for the help of the rheumatoid arthritic patient to ease out their normal activities of the life, and these are the toilet meant specially for the rheumatoid arthritic patients. Now, these assistive devices, the patient with the hip or the knee arthritis get benefit from the elevated toilets. A gripping bar also hold the cane in the hand opposite to the affected knee or the hip. Crunches or the walkers in the extensive diseases will also help as the part of the assistive devices. Then number 7 is supplements. These provide joint rest, reduce the pain, and the prevent contracture. Knifed splints of the hands, of the wrist are used. These maintain extremity in the position of optimum function. In knees, use splints in the maximum extension. Ankle splints are of simple right angle type. So here one can see the assistive devices, the different kind of the sticks and the sports and the walker just to help and maintain the posture of the rheumatoid arthritis patient. And here these are the splints used for the hand, for the knee and for the ankle. These also help in rheumatoid patient. Now, continuing the management, the third parameter is non-steroidal anti-inflammatory drugs, NSAIDs. These provide symptomatic relief but not prevent erosion or the disease progression. These are not effective for monotherapy. These are best to be used in conjunction with DMARDs, disease modifying agents. All non-steroidal anti-inflammatory drugs are equivalent, and non-steroidal anti-inflammatory drugs with the methotrexate is good and safe. Keep in mind the gastrointestinal side effect, renal side effect, and platelet effects of all these non-steroidal anti-inflammatory drugs while prescribing. The next parameter in management is corticosteroids, glucocorticoids for the short term and at the lowest dose for the flare up. Use the oral prednisolone also to discontinue, taper gradually so that you are not going to have the bad effect and side effect of the steroids. Intra-articular corticosteroid triamcinolone is very useful also to give a lot of relief from pain and other associated problems. The next step in the management is disease modifying anti-rheumatic drugs and abbreviated as DMARDs. Primary treatment for the rheumatoid arthritis. These are these improve symptoms, decrease joint damage, and improve overall functional abilities. These have best result if started early and aggressively. These cause disease remission in 50% of the people. There are two types of DMARDs. Number one, synthetic DMARDs. These include methotrexate, leflunomide, antimalarial drugs, sulfasalazine, minocycline, sodium thiamalate or gold preparation, and cyclosporin. The other types of the DMARD are biological type. These are basically TNF inhibitors and these are etanercept, infliximab, adalimumab, certolizumab, and the other. Basically, as one know that TNF is the major cytokine which is responsible for causing most of the problem. If we are able to inhibit TNF by these biological DMRDs, these are going to have the beneficial effect in the management of rheumatoid arthritis. So here one can see etanercept and there is infliximab and there is adalimumab and there is certolizumab pegol, the biological. Then the others are monoclonal antibodies which are also very beneficial for combating the symptoms of rheumatoid arthritis. These are rituximab by the name of Rituxan and these are golimumab. These are also available. Now, continuing management, the next step is alternative medicine. Some dietary supplement like fish oil, fatty acid like gamma linolenic acid and omega-6 fatty acid also help relieve the symptom. These reduce pain, tender joint and stiffness. And the next step is management is surgery, that is to repair, replace or fuse the joint to relieve the pain, and synovectomy to prevent the pain or the tendon rupture is recommended. Severely affected joints need joint replacement surgery such as the knee replacement. So here one can see the synovectomy, joint affected by the synovitis, as one can see. Synovectomy is the removal of the synovium from a joint. As one can see in this case, the joint, there is infected synovium which is shown red here and here is the infected synovium red and that is covered by the capsule which is blue in color, and after the synovectomy, as one can see, the red color synovium has been removed and the blue color capsule is still there. So here one can see the synovium is removed. Now here in rheumatoid arthritis one can see the pannus formation, the other changes in the bone region, and that is causing the severe pain. So one can use their total knee replacement, that is not having these changes which are already there. So that is being covered by these metallic joint replacement and the relief of the pain. So that is the end of the lecture of rheumatoid arthritis. I hope you may like it, and if you like it, please subscribe it. I have given as much best possible, and hope so you will like. And still any question, never hesitate to call to me. And thank you very much to be with me and watching my lecture.